Hello and welcome to another episode of Clean Talk. I'm your host, Brad Whitchurch. It is Wednesday, October 12th at 3 p.m. Eastern Time, and that means we're coming to you live from the Seal Shield Studios in beautiful downtown Orlando, Florida. Very excited about our guest today. She's an infection preventionist. Kathy Warye is the founder of Infection Prevention Partners and a former CEO of APIC, the Association for Professionals in Infection Control. Kathy, welcome to Clean Talk.
Thank you so much. It's my pleasure to be here.
Well, it's great to have you on the show. Kathy, maybe you could tell our guests a little bit about your background and why you're on Clean Talk today.
Sure. Well, I came into the infection prevention arena in 2003 when I was hired to become Chief Executive Officer of APIC, as you mentioned. And it was a really exciting time. My timing was really good because it was on the heels of the first SARS outbreak in 2002, 2003, which really woke us up around infectious diseases. And then MRSA became an issue. And then it was the whole alphabet soup of multi-drug resistant organisms. And we were finding that many healthcare associated infections were actually preventable. So that gave us a platform to really elevate the profession and protect patients. And so that was a very exciting time. Then I spent 5 years, I was recruited by Becton Dickinson and spent 5 years as Worldwide Vice President of Infection Prevention, which enabled me to do more of what I was doing on a global basis. And then I realized that where I had the most energy was around novel technologies, those things that are not 510K products, that are coming onto the market, have FDA approval, have some evidence that could really make a big difference in terms of preventing healthcare associated infections and protecting patients. But it's very hard for those technologies to gain a foothold in the marketplace. And so much of my work in Infection Prevention Partners is helping those companies develop adequate evidence, help them educate around the problem and the technology, and find ways to accelerate adoption of those handful of novel things that could potentially make a huge difference. I also do some R&D work with these companies, and I've also continued to work internationally to try to advance infection prevention practice, mostly in developing countries.
Well, as you mentioned, infection prevention, very near and dear to our heart here. And we share your mission, which is why we have this podcast, because we can do a better job. But many of these cross-contamination infections are preventable, particularly in a healthcare setting. You mentioned emerging technologies. We love talking about that. Can you talk a little bit about that in terms of the challenges you see? You sort of alluded to it with the regulatory process, 510K, how we get innovative solutions to market. Can you talk a little bit about your experience in that regard?
Sure. I think one of the biggest challenges is, you need a certain amount of evidence for FDA to deem your product to be safe and effective. But the evidence that you need for that hurdle is very different than the level of evidence that the infectious disease and infection prevention communities require in order to adopt something, to put it through the value analysis process and to gain approval on an institutional level. And so that can be a real challenge for smaller companies because through the years, CDC, through its guidance and other activities, has really led us to believe that unless you have a large randomized controlled trial, we shouldn't be looking at a new technology. But I've seen a number of things come forward where companies just aren't funded to that level. And the amount of investment going into infection prevention companies on the part of private equity and that type of thing is not large. And so I think we need to find a different way, a multitude of smaller studies that produce similar results, other ways of evaluating these technologies. Otherwise, we are going to just forego the potential of things that could really make a difference. And that's a process of education. It's a process of partners who are willing to do studies with you and get that evidence published, and have organizations who publish be willing to accept things that are not gold standard randomized control trials, because until it's published, it doesn't exist.
Well, that's absolutely right. And we had spoken earlier about some of these challenges on this subject. And as I'd mentioned to you, a lot of people don't realize, but the private equity markets don't even have a category for infection prevention investment. You can invest in medical devices, you can invest in pharmaceuticals, but there isn't even a category for infection prevention. Do you see something like this changing, maybe as a result of COVID and greater awareness, or is this going to be a persistent challenge for us in the future?
I think it's going to be a persistent challenge because, HAIs have been a huge problem for years. And you saw a lot of investment come in the 2005 timeframe. When I joined APIC, the marketplace for infection prevention products was hand hygiene and some personal protective equipment and some diagnostics, and that was it. And then with the awareness around HAIs and with their growing prevalence across healthcare, you saw a lot more investment come into the marketplace, and now the infection prevention category is worth billions. But even though that sounds like a lot, the amount of money going into those smaller technologies that are novel, that can really make a difference, that address things that we have not been able to address in the past, like airborne contamination, it's really an uphill battle. And I don't see COVID really making a huge difference in the private equity interest in these spaces. It's high risk for them.
I agree. And it's high risk because some of the regulatory hurdles, right? There's an indefinite cost, an indefinite time frame. And as you mentioned, for small startup companies, many of them driven by a powerful mission and an innovation that can support infection prevention, they have a tough go of this.
Yeah.
And Infection Prevention Partners in many ways helps these companies. Is that right?
That's one of the goals, yes, to help them develop the post-approval evidence and awareness and the education that's required to get at least a handful of early adopters, and then to be able to move up that growth curve, if you will, to broader adoption. It's that early stage that I work on the most in terms of evidence and key opinion leaders, getting them involved and having them look at the product so that they will advocate for it and get other institutions more comfortable, if you will, with looking at these products and potentially adopting them.
Well, if you're interested in innovative technologies in healthcare, you can check out the Clean Talk YouTube channel. We've been fortunate to have a lot of innovators who share our passion for infection prevention. You can check out the Clean Talk archival episodes for our audience on the Clean Talk YouTube channel. And Kathy, we talked about how COVID perhaps has not helped with the funding side of infection prevention, but we do have a question from our audience. Has COVID helped awareness of HAIs in general? And does it help to acknowledge how prevalent they are, or has it distracted healthcare from combating HAIs? And I know we have a whole talk track around what's happened with HAIs during COVID. How do you respond to that?
I think it's distracted us from HAIs, and the rise in prevalence during the pandemic, I think, is the best evidence of that. As far as COVID-19 being a stimulus, if you will, for greater investment, I hope that the messages we've been sending ever since I've been involved in this space and before then, investment in public health, investment in laboratory capacity and capabilities at every level, from the individual institution up through population health, investment in infection prevention resources, staffing, education, that sort of thing. Those messages have largely gone ignored, if you will, at a governmental level. Individual institutions have invested more in infection prevention, and that is when they recognize that HAIs not only were, detrimental to their patients, but detrimental to their bottom lines. They started investing in infection prevention. But that investment at the public health level has been systematically defunded at the federal level because of other priorities. Look at what we invest in military as opposed to public health. And that was one of the reasons I think we did as dismally as we did during the pandemic. We didn't have the resources. We didn't have the feet on the street. We didn't have the diagnostic capabilities. And so I would like to think that investment on the federal level, as a nation, that we will reprioritize public health, and that we will recoup some of that investment and be able to make these changes that we've been talking about for decades now, that will make us more resilient in the wake of whatever the next threat is, whether it's antimicrobial resistance or the next pandemic or, whatever the case may be.
Well, you mentioned some of the factors. We know now, HAIs, after making progress for so many years during the pandemic, we've seen an uptick, and in some cases, some of the reports I've seen, dramatic increase in HAIs during the pandemic. Um, what else do you attribute that to?
Well, I think the first problem is that we overused and misused antibiotics during the pandemic. The vast majority of patients early on received antibiotics when I think only 18% of them, there was a study that was conducted that determined that only 18% of these patients really had bacterial infections. I understand though at the beginning, not knowing, what this organism really was and how to manage it. It wasn't an organism. These multitudes of impacts on patients, that they threw everything they could at them, including antibiotics. And antimicrobial stewardship teams were distracted. They were doing other things. And so I understand why we overused antibiotics. And once things started to normalize a bit, those antimicrobial stewardship teams, the pharmacists in particular, started looking at prescribing and records and that sort of thing. And we got to know what the pandemic was, or what COVID-19 was about, and were able to reduce the use of antibiotics. But there were a lot of other factors that led to the rise in HAIs. It was a perfect storm. We had older patients with multiple comorbidities receiving very complex care in overcrowded conditions where chaos, in many ways reigned. We had people coming into work in the ICU that had not received the kind of rigorous infection prevention training around measures and that sort of thing that routine ICU staff had. We had situations like tubing laying on the floor from a central line, but if you're trying to save a patient, you're not going to pay attention to that. So we had that kind of perfect storm. And then there were changes in actual care processes, due in part to the lack of personal protective equipment, where pumps and other things were moved outside of the room so that healthcare workers didn't have to go in to see the patient as frequently, preserving their PPE. But this put those things at higher risk for contamination, and that puts the patient at higher risk of contamination. So it was the perfect storm, as I said. I don't think anyone is surprised that HAIs rose, or that antimicrobial resistance has increased, and we've seen it, across the board. MRSA, Pseudomonas aeruginosa, CRE, Acinetobacter baumannii, everything went up, except C. diff. C. diff didn't go up, and I think the reason for that is because there was so much emphasis on environmental disinfection, more emphasis than ever before. And so I think that's perhaps the reason why C. diff, in some cases, actually went down rather than up. And surgical site infections didn't go up because we weren't doing surgery.
That's interesting. I wasn't aware of that fact. You would think with the overuse of antibiotics that C. diff would be an issue, but perhaps not the biggest issue on the hospital-acquired infection side. I'm curious about your thoughts, Kathy. I think it's just phenomenal what we were able to do during the COVID pandemic in terms of getting testing out, getting a vaccine out, increasing production of ventilator pumps. Is any of this going to help us in the next inevitable pandemic?
Well, I think what went right was the vaccine. That was just amazing to me that we were as successful around that as we were. And we owe that a lot to companies in other countries that were working on these technologies where there wasn't a lot of investment because, it wasn't viewed that this was a huge return on that investment. And then the pandemic hit, and all of a sudden that mRNA technology was exactly what we needed. So that went right. But diagnostics, as you mentioned, I think is something that if there is an original sin around COVID-19, it's the way we managed or didn't manage the whole diagnostic issue. Rather than using a test from Germany, CDC chose to create its own, which that's not their area of expertise. The first batch wasn't good, and there was tremendous delay. But even if there hadn't been delay in rolling out that first diagnostic, we just didn't have the infrastructure for tracking and tracing. We didn't have the infrastructure to get those tests to a huge volume of people. And so unlike Asia, if you look at a country that did really well, it's South Korea, because they really have a culture of diagnostics. Asia and Europe have always use diagnostics more than the US. IDSA did a report many years ago that indicated the ways in which we underutilized diagnostics in this country. And one of the reasons for that is our reimbursement structure. Often they're not reimbursed, so hospitals don't use them, as opposed to in countries with other kinds of medical systems, reimbursement's not an issue. So there's much more of a diagnostics culture and a more rigorous approach to management of infectious diseases using diagnostics. So I'd like to think that there will be an examination of that, and we will rethink our relationship to the incredible diagnostic tools and technologies that we have, and that we will utilize them more effectively moving forward. That infrastructure will be in place when the next viral respiratory pandemic, or whatever the next pandemic is, and it's coming, and it's not going to be another 100 years.
I agree 100%.
Yeah.
And lessons learned, of course, COVID was a global pandemic. And we have another question for you, Kathy. Derek says, I believe Kathy mentioned that she's doing work in developing countries. What are some infection prevention concerns unique to those developing countries? And maybe even outside the developing countries, so you can segue into a discussion about MRSA on the Arabian Peninsula.
Yeah, sure. So, I think it's lack of resources, which leads to lack of infrastructure, lack of trained personnel. Surveillance is a big issue in these countries. I remember when we were really concerned about H5N1 emerging in Thailand or some of the developing Southeast Asian nations, where it could be a walk to 5 days to the nearest hospital. And so that really delays your surveillance. I think you also then have places like China, where they try to manage it first rather than announce it to the world. And I hope that after the first SARS outbreak, where they delayed contact from the World Health Organization around that when it happened again, and China is a hotbed for these organisms for a whole variety of reasons, that they would be more willing to act with the global community. But in fact, there was a huge delay, or there was a delay. And when it comes to a viral respiratory organism like this, when it comes to a pandemic, time isn't important. It is the most important thing. The more time that goes by between those first transmissions, person-to-person transmission, and understanding that we need to get on top of this thing, that's the most important thing. And a lot of these countries just don't have the surveillance capabilities. They don't have the personnel. Now, I understand there's been a major multi-billion-dollar investment in one of the global health funds. It's not the World Health Organization. It's another international federation that is intended to be distributed to these developing nations. But they also need to understand how to best leverage that funding and to get those countries to the place where they can be prepared to act with the global community, to not only protect their own populations, to protect the global community as well.
Now, I'd asked you about MRSA in the Arabian Peninsula. Is this the next pandemic that we're going to be faced with? Can you tell our audience a little bit about the risks associated with MRSA and what's happening in the Arabian Peninsula?
Yeah, so this is the Middle East Respiratory Syndrome. It's another coronavirus. And if I could tell you if it was going to be the next one, I wouldn't be on this podcast today. I would be doing something entirely different. I wish I had a crystal ball like that. I do not. But it worries me, because it worries all the global health infectious disease professionals, because this is an organism that has a very high mortality rate. It has something like a 34% case fatality rate. And up to this point in time, it has been contained primarily to the Arabian Peninsula and primarily among healthcare workers. But you have to understand that it's potentially a genetic mutation away from being more transmissible, and what's to prevent it from escaping the Arabian Peninsula and becoming the next pandemic. And while the mortality rate with COVID-19, when it first emerged, was quite high, it wasn't anywhere close to 34%. And even if the mortality rate from an outbreak like this get lower over time, as is often the case, starting at 34% is just it's alarming. It really is alarming. And it's not the only one. I mean, there are more cases of Ebola currently that were discovered a couple weeks ago. So we've got to be incredibly vigilant. And I think what
Polio's back,
happened,
right?
yeah, I think what happened partly with this pandemic is I think we were lulled into a sense of false security with the first SARS outbreak, because that could have been much more. The global health community did a very good job of shutting it down. And I think there were only 7,000 deaths related to the first SARS outbreak. And I think that gave us a false sense of security, and perhaps a little bit of arrogance. Because when this thing started to emerge in late December, early January, I didn't see the level of we've got to mobilize messaging going out on the part of the organizations that I rely on for this type of information. And so I think we need to err on the side of this could be a huge problem rather than our false sense of security. On the other hand, I also know that World Health Organization is in a very difficult position, because if they call it and raise the threat level and it doesn't develop, then they are at risk of people not paying attention to them the next time.
That's right. The
So
boy who cried wolf, right?
yeah, so it's exactly. So it's a difficult situation, but I think we need to be more vigilant the next time, and more vigilant between now and then. I mean, that's what it's about, right?
I
If you wait
agree.
until it happens, it's too late.
I agree. And of course, all of society became familiar with pandemics, with COVID, but we've been battling hospital acquired infections on a regular basis for a long time. We talked about some of the funding issues, and we have a question from Cesar Garcia. He says, why is funding infection prevention technology to help reduce HAIs ignored, especially with how significant HAIs are? We touched on that a little bit, but any more insight there?
Sure. I think that as many of them as there are, as prevalent as they are, as big as the numbers are, and they seem big to us because we're concerned about more patients and the excess expense and that sort of thing. But if you compare that on an aggregate basis with big disease issues like diabetes or coronary heart disease or cancer or some of these other things, on a volume basis, you've got far fewer people being affected. And so companies put their money there because more volume means more return on investment. So it's the smaller companies that see these niches, these things that they can do to engineer better outcomes, that are getting involved in this space and then struggling for that investment.
Now, you've talked about the need for more federal investment. There was, in fact, some federal contribution, particularly to long-term care as it relates to hospital-acquired infections. How significant is that, and is it enough?
Well, it's never enough. I mean, someday it could be enough. I'm hope springs eternal. And I think that it did make a difference in terms of helping populate those organizations with more people that understood these organisms and more training, and perhaps enabled them to buy some technologies and do some diagnostic testing that they wouldn't otherwise have been able to do. I do think that I hate to say there's a silver lining in any of this because so many people died and there's still so much suffering and ramifications of this disease. But if there's a silver lining, it alerted us to where our approach was inadequate. And in long-term care, I mean, it was tragic what happened there. And hopefully this will create a different culture in these organizations and a different mindset in terms of what's needed in terms of investment in keeping these patients, these vulnerable patients, safe. But here in the U.S., we get all excited about something and we want to address it, and then several years later we're on to the next thing, and it becomes deprioritized. And I'm concerned that that's what's going to happen. A perfect example is here in California, we had a pandemic stockpile that was replaced, because elastic masks and all that sort of thing can wear out and degrade. And it was replaced on a routine basis until about 5 or 6 years ago, when it was determined that it wasn't needed. And it wasn't, I don't think they eliminated it, but they just stopped the investment in it. So when the pandemic arrived, even a state like California that had been well prepared wasn't any longer well prepared. So we've got to maintain the investment and the vigilance, and not be distracted by other priorities.
I absolutely agree. And let's shift back to HAIs. We do have another question. You're a popular guest, Kathy. It says, in regards to being unbriefed and not following protocols for infection prevention guidelines, how have traveling nurses impacted the increase in hospital-acquired infections?
I can't say definitively. I suspect that they were not as rigorously trained. Let's put it this way. I don't think a traveling nurse who up until the pandemic did all sorts of things, filled all sorts of, personnel gaps, was as rigorously trained on central line bloodstream insertion and maintenance as an ICU nurse. Now, I may be entirely wrong. I may not be right about that profession, but I know that infection preventionists in the wake of the pandemic probably didn't have the time to do this kind of training. And those personnel may not have been as inclined to be 100% compliant. I don't know. As I said, I don't want to disparage that profession. Thank God we had them. They filled a critical gap. And maybe now we can focus a bit more on them in terms of infection prevention measures. But instinct tells me they were not as well prepared.
Well, and it's a challenge, right? Because every hospital has their unique policies and procedures. And if you're at one hospital, they could be completely different from at another hospital. And if you're a traveling practitioner, I would imagine that could be a challenge, not to mention the potential to bring more varied cross-contamination pathogens into the facilities. So certainly it could be a contributing factor. Let's talk a little bit about MRSA, because we used to always talk about MRSA, and then we were talking about COVID, and we seem to have forgotten about MRSA, but MRSA's on the rise. What can you tell us about MRSA? I know this is a subject of your expertise.
Well, I was deeply immersed in MRSA when I first joined APIC, because after the first SARS outbreak, it was the next thing. And I think it was really that multi-drug resistant organism was what woke everyone up, the general population in particular, to the fact that we had A, healthcare associated infections in our hospitals, and B, that there were these multi-drug resistant organisms emerging. And so I think what really got people's attention was when we didn't adequately address it in the hospital, and a community associated strain developed, and you had young people with no history of hospitalization dying of MRSA. And there were exposés, multiple page exposés in the Wall Street Journal and all over the broadcast news. And then the Chicago Tribune, in about the 2003 timeframe, did a huge expose on HAIs generally, and said, hey, do you know that when you go into the hospital, you could contract an infection that you didn't have when you went in that could be deadly. And Illinois was one of the first states to implement public reporting of HAIs and transparency laws for their hospitals. And then that kind of rolled across the country. But I think the way we did or didn't address MRSA is a lesson for us in terms of emerging multi-drug resistant organisms and how we manage them today. A good example, and it goes back to the whole diagnostics issue, is that in about the 2005 timeframe, the very first molecular diagnostic 2-hour rapid diagnostics for MRSA went on to the market. And this was revolutionary, because up to that point in time, we used Chromagar, and it took a minimum of 48 hours to get a diagnosis. So if you have a patient who's colonized, no signs or symptoms of infection, but colonized and can transmit to other patients and healthcare workers, this was wonderful that you could get a result on that patient's status in a really short time frame. And put that do the infection prevention measures to prevent transmission from that colonization. So we had the ability to do that. We had the technology to do that. Now in the UK, what they decided to do when MRSA became a huge issue there is universal active surveillance testing. So every patient coming into a hospital in the United Kingdom had to be tested for MRSA. And if you look at a timeline of from 2003 through like 2010 or 2012, you will see that when they started that universal active surveillance testing, their rates just dropped precipitously. Now they also did other things. They invested in infection prevention, they hired more people, they elevated the profession. So it wasn't the only thing, but it was a significant factor in that decline. Whereas here in the US, there was tremendous debate over whether active surveillance worked.
Why is it so controversial?
How could knowing the status of your patient not work for you in terms of treating that patient and preventing transmission? I think there were a number of large studies that were done that were badly designed. For example, one of them didn't use rapid diagnostics. They used Chromagar, and it was taking multiple days to get the result back. And unless you capture something like 90% of your isolation days, you're not going to see a reduction from active surveillance. And so some of these studies were really badly designed, but the people who didn't want to see this move forward jumped on those studies and publicized them. And so there was confusion across the profession as to whether or not it was really beneficial. And so what we landed on here, instead of universal active surveillance, was some sort of, institution by institution targeted approach. So test patients going in for high risk surgery, like neurosurgery or open heart surgery or something like that. And you'll see that same timeline in the US and compare it to the UK, and our rates started to tick down, and they're down significantly from the height. But there was a huge gap between, a huge delta between what the UK was able to do and what we did in terms of our rates. And as a result, MRSA is endemic in our institutions today. And I think the lesson around that is, we look at CRE, which is rather deadly,
bacteria,
multi-drug resistant, very deadly. We're not publicly reporting it, so we really don't know how much of it there is on a national basis. And a lot of institutions aren't doing active surveillance testing for CRE. And when you ask them why, the answer is, oh, well, we don't have much of it. But if you have more than one or two cases, your transmission is going to rise, and then it's going to be much harder to get control of it. And if CRE becomes, endemic in our institutions the way MRSA did, I think well, let me put it this way: I will not want to go in to receive healthcare. It's a risk. It's a huge risk for patients.
And isn't that where we're going? I mean, everyone's afraid now, and practitioners are afraid, right? We're having challenges getting healthcare workers and infection preventionists. Is all this related?
Well, I think that the fear of working in an institution is going to subside as COVID-19 subsides. I don't think most healthcare practitioners are concerned about contracting an HAI. They wear personal protective equipment, and those patients are, well, up to this point in time, I don't think that's been a huge risk for them. But certainly, the burden of having to care for these patients, the burden on the patients themselves on nosocomial transmission, the prospect that CRE will develop a community-associated strain like MRSA did. I know microbiologists who are very concerned about this, and they say that, if you get a urinary tract infection with CRE, you could see people who are otherwise healthy die of a simple infection that up to this point in time was treatable with any number of antibiotics. So we're going to see the potential of people dying of infections that were easily treatable in the past. And people from CDC and others have said, we're not entering a post-pandemic era. We are in it. We are in it. And so if we're not going to find these patients who are colonized when they first hit the doors of our institution, how are we going to prevent this from becoming endemic? How are we going to prevent all the deaths that could occur from this?
Well, Of course, we want to take a multifaceted, layered approach to address all of the vectors. And we
That's
talked
right.
about innovations in infection prevention technology. Where do you see the low-hanging fruit? Where do you see the opportunities to help make an impact with infection prevention innovation?
Well, I think there are a number of smaller technologies that address, gaps. Engineered solutions that help make central line access better, um, uh, surgical skin antisepsis better, things like this. But what I tend to look at is those reservoirs of risk that have been unaddressed in the past for whatever reason. And I think one of them is the air, right? And COVID-19 certainly
Absolutely.
heightened our awareness around ventilation, all that sort of thing. But years ago, so in places like Asia, China, they do microbial testing of the air all the time. Now, one of the reasons they do that is because they have a lot of air pollution in China. And years ago, the CDC advised US institutions to not do that because there was really nothing you could do about it. And why know about a source of bioburden that you can't prevent? But even before COVID-19, there were new technologies entering the market that address airborne contamination. And when you think about the fact that 1/3 of HAIs have some sort of airborne component between the host and the organism, wouldn't it behoove us to take a hard look at those technologies? Now, they are vast. There's UV, there's better ventilation, there's all these technologies of which many of them, the majority of them, have really limited evidence. And when they do have evidence, they have laboratory evidence, they don't have outcomes evidence. But there are technologies that do have outcomes evidence. And UV, upper room germicidal irradiation, has good evidence both in the lab and in outcomes. These technologies are available for the operating room. They're available for other rooms where you're doing like procedures, that can put healthcare workers at risk. So these are some things we should look at. There's also, and this is pretty novel, new ventilation technology entering the market for operating rooms and other high risk areas. So if you look at ventilation, in most of the institution, it's turbulent mixed airflow. And the problem with that is in the name, it's turbulent. And yes, you have HEPA filtered air coming into the room and air exchanges to reduce the bioburden. But whatever is in that air before it goes out through the vents is circulating randomly. This is what we use in the administrative offices and in the emergency department, in the ICU and other places, oncology and
Sterile
hematology.
processing
Yeah,
everywhere.
burn
Yes.
units, all those places where patients are at high risk. And then in the operating room, laminar airflow was invented in the late 1960s. And there's a lot of evidence that's come forward that indicates that it really does not do as good a job as we thought we did at preventing surgical site infections. I don't know how much time we have. I can go into all the reasons why. The fact that ASHRAE says you only need a clean zone 12 inches around the surgical table. Well, if you think about the fact that all those instruments and implants are staged on the back wall, in the dirtiest portion of the room, if you heat map those rooms, you've got highly contaminated air outside of that clean zone. And so you open up all the implants and the instruments and then you move them and then you can't even get them into the clean zone because there's no room in that 12 inches around the table. And then they may not be calibrated. They may not have the right velocity to drive the air down. So there are new ventilation technologies coming onto the market that I've seen the evidence, and I personally think they do a much better job of forcing the air down and out and creating ultra clean rooms rather than just ultra clean zones. So if you had a choice between a clean zone and a clean room, what would you choose?
Right.
So it's
Of
really
course.
managing the contamination that we people are creating in that room. You've got the HEPA filtration, which is fine, but we need to control the contamination that from human shedding and the primary source of bacteria in those rooms. And so that I think could potentially, in a passive way, no change in practice, in a passive way, help us reduce HAIs. And
I
as I said,
100% agree.
I think the practice related opportunity is exhausted and healthcare workers are exhausted. And my God, the last thing I want to do is say, you need to do one more thing, right? But if we
Sure.
have these engineered solutions that are passively operating in the background, isn't that something we'd want to look at?
Absolutely. And the examples you gave are not anecdotal. That is the reality, that we have sterile processing rooms where the air is dirty. You
Yep.
have the OR theater where the air is dirty. It's not being addressed. There is a huge opportunity there to improve, I think, healthcare outcomes by addressing the air. But then we come back to the challenges we talked about, these innovative startup companies that have created or identified a technology that's viable. It's a long road. And the standard is, as you mentioned, HEPA filtration and positive pressure. It's insufficient with the
Yeah.
technology we have today. We can do better.
And it's not a performance standard.
Right.
You look at other countries, the UK, France, Sweden, the Netherlands, South Africa, Russia, all have limitations on airborne contamination in the operating room, but we don't. And we don't know because we don't measure. Yeah. So how many of those prosthetic joint infections, implants are highly susceptible to inoculation. How many of those prosthetic joint infections could we eliminate from better passive ventilation or UV that addresses, some of this? Everyone says, "Oh, our rates are low," but wouldn't you want to get them lower? And
Absolutely.
there is evidence that these technologies can actually do that. So yeah, but investment is a huge problem. I'm working with a company now that recently entered the US, and we're just kind of limping along because our ability to get investment to expand in the US has been really limited. So yeah, it's an issue.
It is a challenge that we're familiar with. Kathy, in closing, any predictions for the future of HAIs
Mm.
or infection prevention in general?
Oh boy. Well, I do think that it's a career that people know about now and it's more attractive. I fear, though, that the nurses who've been in these positions for many years are retiring, and that masters in public health people will not have the same kind of understanding of human processes and disease process and that type of thing. But it is becoming, I think, an interesting and attractive career that people didn't know about in the past. I never thought that I would hear the word epidemiology roll off the lips of my neighbors who had no medical training at all. People know what that is. They know, I think, how badly we need investment in infection prevention. I think if there was a referendum today, in the United States saying, that we need to shore up public health in the U.S. and, should we reprioritize some of our investments, the U.S. population would say absolutely. So I'm hopeful that, there will be more investment at all levels. But, the organisms are smarter than we are, and they continue to defeat our ability to prevent them and control them. So
And
I
there's a
see that.
lot more of them, and they've been around a lot longer than we have.
That's right. Their goal is to survive. And so I think that we're going to have to be more vigilant, and drive greater investment and attention to these issues. We face two existential threats as a global society: global warming and antimicrobial resistance. And we really can control, I think, antimicrobial resistance if, as a global community, we come together in a One Health type of approach to do this.
Well, that's
So
a
I'm hopeful.
positive message.
Yeah.
I like that optimism. And Kathy, you mentioned the need for more infection preventionists. I know you're the former CEO of APIC. Of course, APIC has a huge initiative to try and get more people into infection prevention. And if you're in the audience and you're interested in infection prevention, you can go to apic.org to find out more. Kathy, if people want to find out more about infection prevention partners, what should they do?
Well, they can email me at KWARYE@infectionpreventionpartners.com, or go to my website, Infection Prevention Partners, to find out more. I'm love talking about it, as you can tell, and
Fantastic.
trying to be part of the solution.
We appreciate you being part of the solution. Our guest today has been Kathy Warye. She's the founder of Infection Prevention Partners. Kathy, thank you for being on Clean Talk today. If you want to see this episode again, you can go to our Clean Talk YouTube channel and check out our archival episodes there as well for everything on infection prevention. My name's Brad Whitchurch. I'm your host. For my guest, Kathy Warye, you've been watching Clean Talk. Be sure to join us next Wednesday at 3 p.m. Eastern Time. We'll be coming to you live. And until then, remember to keep it clean.